Okay, let's jump right in. The new 2026 ACC/AHA Dyslipidemia Guidelines are here, and believe me, this is way more than just a minor update. We're talking about some fundamental shifts in how we approach patient care, so what I want to do here is walk you through the most practice-changing updates, the stuff you absolutely need to know for your clinic.
So here's what we're going to cover. We'll start with why we even needed new guidelines right now. Then we'll get into the nitty-gritty. Rethinking lipid measurement, what's new with lifestyle and referrals, how medical management is evolving, and a brand new focus on specific populations. And of course, we'll wrap it all up with the key takeaways you can put into practice tomorrow.
All right, first things first. Why now? Why a whole new set of guidelines? Well, it's because the whole scope of lipid management has expanded. This is a big deal. You know, sometimes the biggest clue is right there in the name. Just look at the title change. In 2018, it was all about the management of blood cholesterol. Now, it's the management of dyslipidemia. That's not just a wording change, folks. That signals a massive philosophical shift.
And what does that shift mean in practice? It means we're officially looking beyond just high cholesterol. The scope now formally pulls in hypertriglyceridemia and elevated lipoprotein A, or LPA. We've come to realize that ASCVD risk is so much more than just LDL particles. It's about triglycerides, those leftover remnant particles, and LPA too.
And this isn't just a committee deciding to change things on a whim. This is all driven by hard data. We're talking about major trials that have come out since 2018. You know the names: Fourier, Odyssey Outcomes, Clear Outcomes, and of course, Reduce It. This is evidence-based medicine at its best, prompting these crucial updates.
Okay, so if we're expanding our scope, that naturally leads to the next question, right? How are we supposed to measure all this? Well, what and how we measure has definitely changed. Let's break it down.
First up, a big one for our day-to-day. The Friedewald equation. It's had a good run, but it's officially being put on the back burner. The 2026 recommendation is clear. We should be using the Martin-Hopkins or the Sampson-NIH equation instead. They're just flat out more accurate, especially when LDL is low or triglycerides are high. This is something we all need to check with our labs about.
Next, let's talk about ApoB. This is a new one, at least in terms of a formal recommendation. For our high-risk folks, those with established ASCVD, CKM, or type 2 diabetes, it's now reasonable to measure ApoB to guide therapy. Think of it this way. If LDL-C tells you how much cholesterol is in the car, ApoB tells you how many cars are on the road. It can be a really helpful tiebreaker when you're deciding whether to intensify treatment.
And here it is. This is probably one of the biggest practice changers in the entire guideline. We now have a recommendation to measure LPA at least once in all adults. That's huge. It's not for a select few, it's for everyone. This elevates LPA to a fundamental part of our initial ASCVD risk assessment.
All right, moving on from the lab work, let's get into lifestyle and referrals. We all spend a ton of time on counseling, and these new guidelines bring some really important updates and clarifications. So a few key things here. First, a really clear stance on dietary supplements for lowering LDL or triglycerides? Don't recommend them. The data just isn't there. But look at the flip side, a much stronger emphasis on collaboration. For patients with severely high triglycerides, a referral to a registered dietitian nutritionist is now recommended. And even for moderate elevations in the context of CKM syndrome, that RDN referral is still recommended. This is about using our whole team.
Okay, so we've got the labs, we've got lifestyle dialed in, but what about medical management? The approach here has also evolved, and there's a particular focus on how to handle hypertriglyceridemia.
So the big question is, how do we actually manage hypertriglyceridemia in all these different clinical scenarios we see? Well, the great thing is the new guidelines give us a much more structured, scenario-based approach to follow.
And here is that framework. It's a really logical three-step process. Step 1. For your patients with established clinical ASCVD, if their triglycerides are up, the first move is to intensify their LDL-lowering therapy. Get the LDL handled first. Step 2. For primary prevention patients without diabetes, you'll use the new PREVENT equations to help guide whether a statin is needed. And step 3. For that very specific group with familial chylomicromedia syndrome and sky-high triglycerides, we now have a recommendation for olezarsen as an add-on to diet.
Now this next section is so important. A major update here is the new guidance for specific patient populations, groups that honestly haven't been given enough attention in past guidelines.
Let's start with reproductive risk in women. This is huge.
The guidelines are telling us to consider things like early menopause or adverse pregnancy outcomes, preeclampsia, gestational diabetes, as part of our ASCVD risk assessment. These are now formally recognized risk enhancers that should personalize how we approach prevention in our female patients.
And speaking of pregnancy, we finally have some specific guidance for what to do with severe hypertriglyceridemia. If triglycerides are over 500, it's now considered reasonable to use fibrates, but only after that first trimester, or to use high-dose omega-3s. The goal here is very specific: reduce the risk of pancreatitis.
And then there's this. This is a direct quote, and it's incredibly powerful. Adult cancer survivors with life expectancy of at least 2 years who otherwise qualify for LLT should be treated similarly to people without history of cancer. What does this mean? It's a direct shot at therapeutic nihilism. It's telling us, loud and clear, do not withhold lipid-lowering therapy from our cancer survivors who stand to benefit from it.
Okay, we have covered a lot of ground, so let's bring it all home and distill this down to the must-know changes, the things you can take back to the clinic.
So here it is, your checklist for the 2026 guidelines. First, adopt the new equations for LDL-C calculation. Talk to your lab. Second, measure LPA at least once in all your adult patients. Third, consider using ApoB to guide therapy in your high-risk patients. Fourth, in ASCVD patients with high triglycerides, intensify that LDL lowering first. Fifth, do not recommend dietary supplements for lowering lipids. And finally, sixth, make sure you're incorporating reproductive history and cancer survivorship into your risk discussions. These are the big ones.
So as we wrap up, I'll just leave you with this question to think about. Looking at all these updates, which one is going to most significantly change your approach to patient care first? Is it going to be ordering LPA on everyone? Or maybe changing your LDL calculation? It's a lot to take in, but these changes really give us new tools to provide even better care.